welcome to our, I'll start again. Hello and welcome to our second webinar in our agricultural medicine training course this fall. This is a new webinar and we're very pleased to have Michael Biddle, who is an assistant professor at the Albany College of Pharmacy, Vermont campus, and Catherine Friend, who is a supervising pharmacist at the Middlebury Marbleworks Pharmacy, joining us today for this new webinar presentation. I know you will find it interesting. I know I certainly learned a lot by reading the required articles, and I'm very much looking forward to today's presentation. So, I understand that Michael is going first, I think.
Yep, that's correct.
That was smart of me because I saw your picture, huh? And then Catherine will be joining us later. So this is a new partnership for the task force, and we're very glad for this webinar to be happening today. Michael, go ahead.
All right. Thank you, Jean, very much. This is my first time doing Blackboard Collaborate for you guys. Even though I'm an educator, I've not really worked with the system before, so if I fumble around, I apologize ahead of time. It's also weird not being able to see people face-to-face and interact with them. But feel free to send any questions out there through the chat. I'll be reviewing through that as we're going through. I have some interactive stuff, too, that we'll do through the chat window as well. When Jean first approached Catherine and I about doing this presentation, I wasn't totally sure what we were going to do. But always being the advocate for pharmacy, especially having pharmacy students to advocate for, I figured it'd be good for everybody to kind of get a review of what pharmacists can do. And the pharmacist role has really changed a lot in the past 5 years, if you even go back farther. So I just kind of wanted to review what a pharmacist can do, especially a rural community pharmacist, since that's where most of the patients for farm health are going to be. Just so that you all know what resources are out there and how a pharmacist can be a helpful member in that healthcare team, especially in the rural setting. So that was kind of the impetus for this presentation. So today, a few objectives up here. I don't expect you to memorize everything a pharmacist can do, but really I just want you guys to get away from this, what options the pharmacists can, what things the pharmacists can do in healthcare to help out all of our patients. So I'm going to focus mostly on the scope of pharmacy practice and then really hit on something called medication therapy management, which is a relatively new field for pharmacists, especially in the community pharmacist setting, to expand patient care a little bit. And that's probably the one that you're going to see most out in the community pharmacies right now. Some of the other things I'll be going over are going to be in like little pockets and areas, not necessarily in Vermont, but things that are on the radar that you might see in the next few years or so. So I want to take a quick poll first. Before you even do this presentation, I want to ask everybody what you think a community pharmacist does. So if you want to just type like a word or whatever in the chat box, we'll see what everybody thinks. Yeah, we got advise, good. Yep, provide information on the medication dispensed, yep. Anybody else? Yep, immunizations, good. Provides meds for folks with prescriptions, good. Educates healthcare providers and community members, good. It sounds like you guys have a good understanding already of what pharmacists do, so some of this might be a refresher for some of you. Provides information on medications as needed, yep. Good. So, it sounds like you guys have already had some pharmacists in your lives, so I'll give you a little more background on what pharmacists are. So, just a little background on our education. And this is the new pharmacy curriculum since I believe back in 2005 when we actually went from a bachelor's program to an actual doctor of pharmacy program. The differences between the programs are a little bit. I mean, there's a little bit more clinical stuff in the Pharm.D, but for the vast majority of pharmacists, a pharmacist is a pharmacist no matter what the background is. And any pharmacist is always willing to help out with any kind of patient issues. So to start out, pharmacists, as you can see, we usually have 2 years of pre-pharmacy coursework, which is very chemistry heavy and biology heavy, lots of biochemistry because we're working with medications in the body. Also physics and things like that too. But then after our 2 years of pre-pharmacy coursework, now the majority of students do get degrees already in their undergraduate and they come to pharmacy school, but it's not required. Because we really do a lot of the training for pharmacists in pharmacy school itself. And it's a 4-year program for all of pharmacy school. The pharmacy school up here at Albany College of Pharmacy, where I work, we're just a 4-year program. So students will come from UVM or St. Mike's or any of the other states in the area and also farther states away to come and just do the Doctor of Pharmacy program. So we're just a 4-year program here, but in that 4 years across all pharmacy schools, the first 3 years is basic classroom and laboratory work where we learn about just the basics of medicine and how they work in the body. So we do biomedicine, pharmaceutical sciences. We also cover social and behavioral administrative sciences too. So we learn how to talk to patients, work with patients' lifestyles, encourage them to make changes, those kind of things. So it's more than just the medication dispensing. And of course the clinical sciences too. That's kind of the art of medicine and how do you actually treat patients with diabetes or hypertension and which medications work best in certain cases. After the 3 years of classroom work, students actually do 1 full year of rotations. And these are advanced pharmacy practice experiences. During these rotations, students go out for anywhere from 4 to 6 weeks, at our college it's 6 weeks, to actually work as pharmacists under the supervision of a licensed pharmacist. So you might see students out there that are doing rotations at their community pharmacy. If you see a student changes every 6 weeks, that's why. But you'll also see our students too as interns at the community pharmacies as well, where they can, it's beyond the course itself, they're just working as interns for that pharmacy. So you might see them there too. But the APPEs are a way for all the pharmacy students to kind of have the same experience so that when they get out in the practice, they kind of already know what's going on and also get an idea of where they want to practice in the future. So after their 4 years of pharmacy school, they have options. They can either get hired as a pharmacist at a community pharmacy, a hospital pharmacy, wherever. You know, they can start making money and earning a living then. But there's also additional training they can go through after pharmacy school. And these are just a couple of the examples. The first one is postgraduate training. And the biggest one that a lot of pharmacists might do, or some of our students go to, is residency. And it's similar to what a doctor would do after medical school. Only doctors are required to go to residencies to actually get their specialty. In pharmacy, the residency is not required, but it's a faster track for a student to go into more clinical realm, whether if they want to work in a clinic or if they want to work on rounds with the doctors in the hospitals. It's kind of the faster track to doing those kind of things. And they can range anywhere from 1 to 2 years. For example, my residency was a 2-year residency in family medicine. And that's where I learned a lot of the clinic-based management stuff and how to run my own clinics and work with patients in general. So the residency is more of, I always think it was like kind of like the doctors do with the extra residency training. Fellowship's a little bit more research-based. That's more for drug companies. So if a student wants to get more into the drug development or clinical research kind of stuff, they would go to a fellowship and do more research-related activities. Both residencies and fellowships are pretty competitive. So not all pharmacists are going to be able to have the opportunity to do that, but it just adds extra training for them outside. As far as the other kind of certifications, there are board certification specialties. Two of the ones that are probably of most interest to most of you all are the pharmacotherapy, which is just the general, after a residency, a student or a pharmacist can sit through this exam, and it's kind of just a national certified exam to show that yes, this pharmacist is a pharmacotherapy specialist. There's not really a whole lot else attached to it except for the letters, although it is gaining a little more clout out in practice, where you might, where some hospitals may require a pharmacist to be certified to actually work with patients. And the same thing with the ambulatory care certification. This one is more focused on outpatient pharmacy, so lots of anticoagulation things, things like managing chronic diabetes and hypertension. And this is kind of where you're going to see mostly for family medicine kind of things. And this one's relatively new too. You're probably not going to see it very often, but as pharmacists start getting more of these specialties, you might see some more of these letters come up. In addition to those certifications, we can also get additional certificates because we are healthcare providers. We can actually get a diabetes certification, so we can become certified diabetes educators, certified asthma educators, same for anticoagulation. Pretty much anything that's a chronic disease, if there's a certificate available, usually pharmacists are eligible to sit for it. And it all depends on the pharmacist, where their practice is, and what they feel like they need specialty in if they want to sit for these. Some of these special certifications come with the ability to bill at higher levels so they can actually support their practice, while some are just certifications that you completed a training program. But anyway, I don't expect you guys to know a lot of the details of these things, but just showing you guys that there's actually a little more to pharmacy than just the Pharm.D degree if people want to pursue additional certifications. And you might see these in your local pharmacies. So a little bit about the scope of practice of pharmacy and what we do, which from the first question I asked you guys, it sounds like you all have a pretty good handle on what pharmacists typically do. But of course, the biggest thing and the very first thing is ensuring appropriate therapy and outcomes for patients, and that includes medications as well as lifestyle changes that get lumped into that. Also, patient counseling comes in here, making sure that the patient can actually use the medication in an appropriate way. So that's where the counseling and also monitoring the patient for outcomes and things like that. We also, of course, dispense medications and devices. So that's the role you mostly think of a pharmacist, where they fill a bottle, label it, and hand it to you to counsel you on it. And also the delivery of medications and devices. So under dispensing, which Catherine will talk about a little bit later, is immunizations. Because technically immunizations are medications. Pharmacists have been able to immunize for, in Vermont, I think for at least 10 years, probably longer than that. But this is kind of where the scope of practice of pharmacy is increasing. We have immunizations on board now under the medications. But in addition to just medications, we can also dispense devices as well. Most common one is going to be like a glucometer. But those are included too. Also beyond the dispensing role, we also do health promotion and disease prevention. So you often see that community pharmacies might have blood pressure screenings or heartburn screenings or osteoporotic bone screenings. So we're really about preventing problems in the community as well, and also providing education too. We also, survey and monitor the population as well for public health issues, and of course promoting the safe use of medications in society, which is just kind of falls under our umbrella. And finally, the last thing is health systems management. This encompasses the day-to-day operations of the pharmacy and even just general practice. Also managing medications throughout and within the health system. So if you're part of a hospital, you're part of that medication process. Also, if you're a community pharmacist, you can work with the doctor to help manage patients' medications. And of course, this also includes collaboration with other healthcare professionals, which is what this whole presentation is about with the agricultural medicine. So we can integrate into those teams as well. So a little bit about public perceptions of pharmacists. So we are the third largest healthcare professional group after physicians and nurses. So there's a lot of us out there. And we're also consistently one of the most trusted healthcare professionals according to Gallup polls. We go back and forth between nurses and pharmacists as number 1 or number 2, but we are pretty well trusted. And also the public sees pharmacists about 12 to 15 times more per year compared to their doctors when they're actually seeing them about 2 to 4 visits a year. So the pharmacists really know their patients, especially the regular ones that come in. We can tell if a patient's kind of feeling off. We really develop that rapport and get to know the patients really well, hence why they come see us more often, and of course they're coming for refills too. So we're kind of set up to do some more things with patients. So some of our potential, just some fast facts that I pulled out of the article you guys we had posted for the reading. So there's an expected shortage of physicians by 2020 to be about 91,000. And it's mostly going to be in primary and elderly care, because primary care and elderly care don't pay very well for reimbursements from Medicare and Medicaid, as probably most of you guys know if you worked in a doctor's office. So that's not really the cool field that a lot of people want to go into. But this is why there's been an increase in nurse practitioner schools and PA schools, and then also an increase in what a pharmacist can do in practice too, is to fill this gap, because it's been hard to get other primary care doctors out there, especially if you think about the rural settings in Vermont, where there might not be a lot of things going on in the town. So to bring people in, it's kind of difficult. But 90% of the U.S. population actually lives within 5 miles of a pharmacy, which is pretty interesting. So if you think even in these rural settings, there's usually at least a pharmacy somewhere, and usually the pharmacy might be closer than the doctor's office. So we are the most accessible healthcare provider because we're out there. It's easy to walk up to us and ask us any questions that the patients may have. So we're accessible. Also, 81% of adults take at least 1 medication, which probably isn't surprising, and that includes over-the-counter medications. And about 1/3 of adults take 5 or more medications, which this magic number of 5 in pharmacy literature, that's where it starts becoming confusing for patients to take medications. If you think about how many medications a patient has to take, 5 if they have different schedules, it's kind of a lot. So there's a lot of potential for errors for patients. And it's not uncommon for a patient with a chronic disease state like diabetes to have at 5 medications, and that's pretty normal, considering all the disease states we're trying to prevent in that patients too. And so you can see where the need of the pharmacy comes in. And just kind of a general overview, pharmacists are positioned and trained to provide patient care services in underserved areas. Pharmacists, even though we don't necessarily diagnose and we don't have prescriptive authority, we can put patients in the right direction and refer them where they need to go. I always tell my students when I teach in self-care that, you're going to have those patients that walk into your pharmacy because they think they can take care of like a severed finger over the counter. But, it has to be our role to put them in the right direction and let them know that they need to go get extra help somewhere else. That's kind of an extreme, but you'd be surprised what kind of questions we field as pharmacists in practice. So this is just a general overview what I'm going to talk in the next few slides about some of the basic services that we offer as pharmacists. So these are the basic ones that you are more likely to see in community pharmacy. And then the more advanced services that, definitely immunizations you'll see in community pharmacy, but some of these other ones may not be as common. It depends on the pharmacy practice, also the state in which you're working, and the comfort of the pharmacists too. But I wanted to put these on your radars as well, because as pharmacy keeps growing and as the needs of the community for healthcare keep growing, these services are going to become more and more essential, and you're going to see them more often. So diving into some of the basic services. So like a lot of you had mentioned, medication dispensing is definitely one of the basic services that we offer. So this is the classic role of the pharmacist that you think of when you think of pharmacists. At least when I talk to people and I say I'm a pharmacist, that's one of the first things they ask me about, beyond saying that, oh, you're a drug pusher, which is always a fun joke. I just realized I didn't really mention what my practice was. So I don't work in the community setting. I used to work in the community pharmacy when I was in residency, and I did all my internship at community pharmacy. So community pharmacy is my first love. I currently practice at Richmond Family Medicine down in Richmond, Vermont, or up in Richmond, Vermont, wherever you're located in Vermont. And I just work at the clinic with the doctors, with patients with diabetes, hypertension, cholesterol. So I do a lot of the clinical management of those patients with the doctors working as a team. So I'm not dispensing medications, but I'm working at the point of care with the doctors to make sure that patients are getting the right care, we're giving the right medications and things like that. So I can talk more about my role later on if you all are curious. But, you know, just to give you my background. Sorry, I forgot to mention that before. Anyway, our classic role as pharmacists, of course, it involves getting a brief patient history for new patients, because we have to know, what a patient's background is. First of all, their age and who they are and all that kind of stuff. We also need to know what their current medications are, so that whatever medication they're bringing into the pharmacy that day to fill, that it doesn't interact with that. And also what medical conditions they have, so we can find out if it's the right medication or if they're going to have any problems when taking it. Biggest thing that I always emphasize for my pharmacy students that often is overlooked is allergies and adverse reactions. The last thing you want to do is give a patient a medication they're allergic to, or give them a medication they had an adverse reaction to. And then finally, insurance. Unless the patient wants to pay cash, which the medications are really expensive, unless you're getting a generic, the insurance information, or who's going to pay for the med. So after the brief patient history, we do the prescription processing, which I'm not going to walk you through all that process. Just know there's magic that goes on behind the counter, and the medication is filled. After we process the medication, we also do a prospective medication review. This is where we look, even with a patient that we've had for a while at our pharmacy, every time we get a new prescription in, we always have to go back and look at all their medications to see if there's any interactions that may come up. Even though we have computer software that does that now, there's still things that get missed that people that aren't in the software programs, or even you get ancillary red flags that might not mean anything. So this is really important step for pharmacists, and why we still need pharmacists around. So insurance processing, again, just chalk it up to magic in the computer. So we process the insurance, find the copay, and then when we give the medication to the patient, we finally do patient counseling. And it is a federal law that we have to counsel all patients on new medications. So that's where, a patient comes in with a brand new medication, we have to counsel them on how they take it, when they take it, what adverse effects to watch out for, what they can do to treat those effects, and knowing when there's major side effects that they need to report to their doctor. A good pharmacist can do this in about 2 minutes or 1 minute, depending on how fast you are. It goes pretty quick, but it's really only with new medications. You can still do counseling on patients with refill medications, but the federal mandate is just for new medications. But I'm not going to dive too much into this, because if you've been to a pharmacy, you've kind of seen this already. A little expansion on the patient counseling. So again, we must offer to all patients receiving a new prescription the counseling, and that's over 90 that applies that. And it's supposed to be for government-sponsored programs like Medicare and Medicaid, but it's extended to other insurances too. It's just easier to counsel everybody, and it's the right thing to do for new medications. So the counseling, of course, can include the drug name, dose, formulation, how it's administered, and the duration of therapy. We also go over the indication and mechanism of action, and we try to be as simple as possible. The question is, does giving info sheet count as counseling? No. That's a good question. That's the one that actually a lot of our students ask. Just giving a counseling sheet to a patient doesn't count. The patient actually has to be verbally offered a counseling session from the pharmacist. And this usually comes from the technician, where the technician will like, oh, do you want to talk to the pharmacist about this medication? And the patient can say yes or no. If they say no, we just say, oh, go okay, and then if they say yes, then we go through it. But just that handout, no, it's not enough, because you have to have that rapport. So other things I go over, so common side effects, severe side effects to watch out for, suggestions for self-monitoring. So if you're giving a patient a blood pressure medication, we tell them to keep checking their blood pressures, because otherwise they're not going to know if it's working. Proper storage, which is very important because certain medications require special storage or can't be exposed to light or really need to be avoid moisture environments and things like that. Also, refill information. Instructions for missed doses, which come up a lot. We get a lot of questions about, when people miss medications and when they can take the next one. And of course, device education and demonstration. Especially with diabetes, there's a lot of new devices coming out. Everything from the Afrezza, which is an inhaled insulin, to some of the new pens that are coming out for insulins. It's going to be really important that patients get the education on these devices because they are confusing and they're not as straightforward as you might think they are. Question on the discussion board is, can pharmacists give education regarding OTC herbal products too, like dose, mechanism of action? Yes, we can. I'm actually going to go into that a little bit too in over-the-counter counseling, but that's another good question we get from patients is they might see something on Dr. Oz, and they'll ask us, like, hey, what do you think about this? And I can't remember what the dose is. So in general, in my practice, I'm okay with herbals and naturopathic medications as long as they're using some evidence base and they're not interacting with the medications. So I get patients that come in and are asking to take red yeast rice instead of a statin for their cholesterol, and we work with them to find the right dose that's been studied and also find the right product, because over-the-counter herbal products, well, all the herbal products aren't regulated by the FDA, so the pharmacists know what to look for. There's certain labels to look for and certain manufacturers that we know and trust that we make recommendations. So yeah, herbal products are definitely within our realm of reason. Some pharmacists are more comfortable with than others. Some pharmacists have access to other resources more than others. I'm lucky that I work at the College of Pharmacy, that we actually have a lot of online resources for herbals. So it just depends on the pharmacist in practice. So great question. All right, so a little self-care and OTC counseling. So this is kind of the other aspect, and that's a great lead into the herbals discussion. So just a little background. In 2010, 240 million people spent $24 billion on over-the-counter therapies. And I didn't find out the data if this was just OTC, like FDA-approved OTC therapies, or this also included herbals. But I'm willing to bet this is just the OTC-approved therapies and not the herbals and vitamins. So it's a pretty big market, and this is where a lot of the rural patients, especially in farmers and stuff like that, are going to find a lot of their therapies because they often don't have time to go to the doctor to find out what's going on, so they're going to try to treat it over the counter. And they have a lot of options. There are more than 700 OTC products available, and a lot of these are duplicates with different mixes of different products, so it can get really confusing. If you haven't done so in a while, just take a little stroll down the OTC aisle in a pharmacy, and you'll realize how overwhelming it can be, where you're trying to find the right thing. And many of the common conditions can be treated with OTC medications, and more of the conditions are coming up. And I'll go through some of the on-the-horizon over-the-counter medications that you might be surprised about. So just to kind of give you an idea, I'm not going to go through all of these, but these are some of the conditions that actually are amenable to self-care treatment, depending on the severity of the patient's case. But all these are right out of our self-care textbook that I use for our students here at the college to teach. And this is like a sampling of the most common ones that are out there. So the ones that you probably recognize the most are like cough and cold, allergies, headache, of course, and fever. But some of the ones you might not realize are things like vaginal disorders, like yeast infections, or pinworm infections for kids. There's stuff over the counter for stuff over the counter for, of course, hemorrhoids and things like that. So there's a lot of options. And this is only the first page. So they have eye disorders they can treat, and ear disorders and things like that. So a whole bunch of different options. You can see where it can get confusing for patients. Probably the most important ones that might apply for agricultural medicine, of course, are going to be things like the cough and cold over-the-counter therapies, and then maybe even like the antifungal skin infections and some contact dermatitis and things like that. But even that being said, you're going to have burns and stuff. So just being aware of what's available to be treated over the counter is just something I wanted to put on your guys' radar. These are entire topics that we can devote entire classes on by themselves, so I'm not going to go too into it. My goal was just to give you guys an idea of what we can cover over the counter. So a couple of new and future medications on the horizon. So some new ones that got recently added are Flonase and Nasacort, which we use for allergic rhinitis. These used to be prescription-only products, but now you can actually buy them over the counter at prescription strengths. And they got shifted over the counter because they're pretty safe in patients and they can self-regulate them. So this has probably been one of the biggest changes in therapy for over-the-counter therapies in a while, because now instead of using antihistamines, we can actually use a nasal steroid, which these hit more symptoms than just the oral antihistamine tablets, and they have fewer side effects. So that's a pretty cool development. One of the odder developments is the OTC use of oxytrol for women, which is used for overactive bladder. So patients that have bladder urge and stuff like that. This is actually available over the counter now too, which is kind of interesting because you know, oxytrol is not necessarily like, it's safe, but there are side effects to it, and I sometimes worry about patients treating maybe symptoms of urinary tract infections they might think is overactive bladder, but actually being other symptoms. So I haven't had too many questions about this, but something to keep on your radar. And then if you've seen anything on any of the commercials, Nexium is over the counter now. I think it's Larry the Cable Guy is the promoter of that. But there have been others like Prevacid and Prilosec that came over. Oh, he's a Prilosec rep, not the Nexium guy. Prilosec have been over the counter for a little while, but Nexium's the newest addition. Question is, do OTC medications cost less than a prescribed medication like Flonase OTC versus RX? It depends. Sometimes if the patient has insurance, their insurance will still pay for the prescription product. So for them, it's probably cheaper with a copay to actually get the prescription product. Nasacort and Flonase, I actually use Flonase, and I think the last time I bought it, it was like 30 bucks. Yeah, about 30 bucks for a 30-day supply. So it depends. But that being said, some insurances are actually wise to this being over the counter. So often if they see there's an over-the-counter option for it, they won't pay for the prescription anymore. But if you're thinking about prescribing, I would suggest you go ahead and try prescribing the prescription form of it to see if it works. And then if they don't pay for it, the pharmacist can kind of point the patient in the right direction for the OTC therapy. But they should be cheaper, ideally, in the long run, once we get some generics out there. But if you were going to pay cash for like a Nasacort prescription, then it would probably be more expensive than the over-the-counter product. Long answer to your question, but I think I got it there for you. So some other future medications coming down. This is going to be interesting. Erectile dysfunction. So Viagra is actually going generic probably next year. So often when drugs go generic, they try to look for the OTC option to get some more money. So there's been rumblings about Viagra going over the counter. Same thing with Cialis and Levitra. Migraine medications. Now that Imitrex is generic, and a lot of these are going generic, so Maxalt and Relpax are all generic now. You know, the bottom's kind of falling out of the migraine market, so they're looking for other reasons to use these medications. So it kind of makes sense for migraine medications to go over the counter. They're not over the counter yet, but keep an eye out for them. They're relatively safe to use, but they'll have to go through some more regulation and stuff like that for OTC use, but keep that on your radar. Crestor or cholesterol medications have gone back and forth for OTC use. There's some talk about using them for a special type of OTC use, but then also pharmacist dispensing too, but that might be an option. Overactive bladder, usually when one thing goes over the counter, other things look for over-the-counter uses. So Vesicare, Detrol, and Sanctura, they might be coming over the counter soon. And then I've heard rumblings about Flomax too, possibly going over the counter. But I'm not so sure about that one either. And that's used for BPH or benign prostatic hypertrophy. So some interesting things to consider that might be coming out eventually. So our role in self-care, of course, we first identify the condition through a brief interview. So we want to get more information from a patient, just like any other healthcare provider would. We then want to determine if a patient is a candidate for self-care. So looking for any red flags, can they be treated safely? Are they going to bleed out? Like, are they going to be stable enough? Do they need extra help? And then, of course, we're going to recommend the appropriate product if they're eligible for self-care. We're going to counsel them on that product and then, of course, recommend an appropriate follow-up. So that's just the process that we use. I just wanted to lay it out there because it's very similar to what other healthcare providers do for their patient care process. And we just follow it because it's over the counter, and we want to make sure we gather enough information. The other thing is, too, is that sometimes patients that come to our pharmacies and ask for OTC recommendations, we don't know who they are. So it's really important for us to gather thorough histories and get as much data as possible. So sorry for this big slide here. Apparently we can't do actions in Blackboard Collaborate, so just kind of follow along with me. Compounding is probably something that some of you might have used. Some of you might not even know what it is. If you ever need a specialty product made by a pharmacist, that's what we do is compounding. And now all pharmacists can do it, but I'll dive into that a little bit. But pretty much a compound or medications or products that are made specially for a specific patient. So for example, if there's a patient that cannot tolerate lactose or lactic acid, which is a normal diluent in a lot of pills, or lactulose, sorry, then we can actually, a pharmacist or certain pharmacists can actually compound those pills without that active ingredient. So, so depending on the ingredients, whether it's prescribed or requested by the patient or suggested by the pharmacist is kind of where the medications can come from. For the most part, they're going to be prescribed by their doctors because most insurances want to see that the doctor did prescribe it. Rarely will a pharmacist actually suggest something and give it to a patient just over the counter. They might suggest something and then request the doctor write a prescription for it. But sometimes pharmacists will prepare like special hand creams for certain patients, as long as the products they're using are over-the-counter products and are allowed to be used without a prescription. But keep compounding in the back of your mind for patients that, for example, might not have, well, actually, here we go, recommendations. If a specific product strength or dose is not available, so a good example that comes up a lot is patients that can't swallow, making liquid formulations for them from the basic product would help, especially patients with like G-tubes, things like that. Also, making a medication more palatable, so anytime you add a flavor, for those of you that have kids, whenever you ask your pharmacist to make sure that amoxicillin takes a grape instead of the nasty penicillin flavor, that's compounding, a basic kind of compounding, but we're flavoring the agent to make it easier to swallow or for the kid to take. And we also have flavoring, too, for pets as well. For example, like avoiding unwanted ingredients, so like gluten or dyes, lactulose, those kind of things. We can actually specially make these products. So dosage forms that can be compounded, any form can pretty much be compounded. It just depends on the limitation of the pharmacy doing it. Question is, do compounded meds in general cost more for a patient? Yes, they will sometimes because a lot of insurances might not pay for the specially compounded product. And the patient can actually submit the receipt to their insurance to see if they might get reimbursement. Some insurances might pay for certain compounded products, but that's the thing to check if you ever find a patient that needs a special product. Feel free to call the pharmacy that does it, if there's any compounding pharmacy, and they'll be happy to tell you what the cost would be so you can give the patient a heads up and if they're willing to take that hit. An example of a product that I've had compounded before has been actually testosterone, because testosterone manufactured comes in only certain strengths. Some patients might want lower amounts of the cream to use, so pharmacists can actually compound higher concentrations of some of the hormonal replacement therapies. Another example is like estrogen therapy. There was for a lot of compounding pharmacies a big push for biosimilar estrogens, where you actually match the estrogen level for the patient's estrogen, their their actual estrogen level in their body so that you're not over-replacing. There's not a lot of evidence for that, but you might see compounding really coming up with patients that want specific amounts of estrogen. Also, there's veterinary compounding, which I just kind of threw in there because I know we might have some veterinarians out there. But if you're a compounding pharmacy, you're going to do a lot of veterinary compounding. That's kind of like your bread and butter, along with human compounding too. But a lot of products need to be specially dosed for animals. So an example, a great one. I get my son's meds compounded because he's allergic to milk. It costs about $15 a month more than usual. So for that trade-off of having to avoid something that the son's allergic to, like $15 a month probably, isn't bad considering what kind of reactions you could have to other things. So that's a great example. Thank you for sharing that. If the patient has a PC provider, do you access the patient information from him or her? We try to. If most pharmacies don't have access to the patient's, the provider's electronic medical record. Some pharmacies do. But we can usually gather the information we need from the patient directly. If it's somebody that we really need to double check, we're not sure about their background and we want to make sure, yeah, we can always call the doctor to find out. But sometimes it takes a long time to get a response. But in general, we can get most of the information we need from the patient directly. Unless there's a communication barrier or a language issue, we're usually pretty good about finding out that information. And again, the compounding availability just depends on the expertise of the pharmacist and the resources available. Most pharmacies can compound some basic things like magic mouthwashes for thrush, or mixing a couple of creams together if you wanted a steroid cream and antifungal cream. Those are kind of some simple compounding things. But for more of the advanced things like creating a product that doesn't have milk products in it, that's going to be more of a specialty compounding pharmacy. In Burlington, there is a compounding pharmacy locally. And I know there's one in Rutland too. So some of the rural areas you might have to really kind of find out where they are. But most of the compounding pharmacies will mail medications. So even if you don't have one locally, you might be able to set up a mail order option for some of the rural patients out there. So another thing we offer as pharmacists, of course, is drug information education, which I think somebody had mentioned before too. So you might have experienced a pharmacist giving you some education. So as medication experts, we have the training and resources to answer a lot of the questions about medications for both providers and patients. It's funny when patients walk up to the counter and ask, "Oh, can you answer a question for me about a medication?" Because we are the medication experts. So this is kind of a plug for us that if you have any kind of medication question, feel free to call any of your pharmacies. Depending on how busy they are, they're usually happy to answer those kind of questions or get back to you. And we have some different resources that you might not have access to, especially some of the drug information resources, and we can often find that information a little faster too than you have to dig through Lexicomp or Micromedex to find the answers as well. In addition to this basic drug information knowledge, we're also trained to critically evaluate the literature and implement evidence-based recommendations. So, it's a great opportunity to ask a pharmacist to come in for a lunch session and then tell you all about the new hypertension guidelines or tell you all about the new anticoagulation guidelines. Again, depending on the pharmacist, they might need to have more time to get it ready, but if you're ever kind of, wishing that you had that opportunity for somebody to come in and teach you, a pharmacist is a great resource to reach out to and just maybe ask if they'd be willing to do these kind of sessions. We're also trained to adapt and present drug information to a variety of audiences, which kind of ties into the last one. So, again, a good resource for providers and other healthcare professionals to remain up to date on guidelines and therapies. So, we critically evaluate literature, we stay up to date on things because we need to know if medication recommendations are changing, if medications are falling out of favor, also to be able to make sure our patients are getting the right kind of care. So you might get phone calls from pharmacists that might remind you and say, "Hey, did you know this new guideline came out and now we don't recommend doing this medication in these patients?" We'll just give you some friendly reminders sometimes. So when a pharmacist calls, it's not to scold, it's just maybe to remind you about it or give you an update. And we're happy to forward those along to you as well too. Especially if you've never heard of it, we can always send you that information too. So some categories of drug information question, of course, the biggest thing, adverse effects, but we can answer any of these. So questions about herbals, compounding, anything, pharmacokinetics, how long is a drug going to be in somebody's system? Poisoning and toxicology is a big one, although I'd recommend you probably call the drug toxicology hotline first because they are the best resource for toxicology information, and they can get your answers a lot faster than probably a pharmacist can. I mean, we could get you information, but these guys are specialized. Other common questions like pregnancy and lactation. So if you have those patients that come in that want to get pregnant or want to try to get pregnant, but they're taking a bunch of medications, we can tell you which medications might need to be pulled off, which ones are less safe, kind of give you an idea of what to do for the patient to prepare them for the pregnancy, and even after the pregnancy for lactation. So I wanted to touch a little bit on 340B medications. This is something that some of you guys might have an idea about, and some of you guys might not have heard of. So I'm not going to go too into detail, but just to let you know that it was this class of medication, 340B, was created in 1992. And it's a way to provide discounted medications to patients in qualified safety net clinics. And the eligibility can be found on the website I posted here. You can look at it. But there's only certain clinics that can do it. And usually they're federally qualified health centers like family planning clinics, Ryan White or HIV intervention clinics. Some of the community health centers in Vermont all around, like the one in Stowe and the one here in Burlington, those qualify too. So they have 340B medications. Pretty much they have to meet certain qualifications for the discounted drug program. And those patients are usually underserved, have low income, fall in the gaps between healthcare and stuff like that. So it's really trying to get the costs down for the patients that really need the extra help on their medications. So the discounts can range anywhere from 20 to 50% on the average wholesale price. And this can mean a difference of a patient paying $100 a month for a medication to only paying like $4 a month for a medication. So it's a pretty big discount. So if your patients qualify for this, it's a great opportunity for them to save some money. And it's actually a manufacturer mandated to offer these discounts too. So it's not going to go away. It's actually a federal mandate that this is part of their being approved for giving the medication is to offer these discounts. Now, community pharmacies can actually contract with the qualified entities to store and dispense the 340B medications. So a patient, like for example, if there's a clinic in the Northeast Kingdom that it qualifies as 340B, but they don't have any room for a pharmacy in their office or room for medication dispensing, then they could contract a local pharmacy and be like, hey, we're going to send all of our patients to you if you keep these medications stock and dispense them for us. But if it's done at a separate community pharmacy, the community pharmacy has to keep track of those medications because they are owned by the 340B program and they can't mix and match. So, and they can only dispense those medications to patients from that clinic. It's a little confusing, but just know there's a 340B program that offers discount medications, and if you think your patient might qualify for it or your clinic might qualify for it, it's something to look into and a good service to offer patients, especially in the rural setting. Wrong direction. So medication adherence. So beyond being medication dispensers, we also like to make sure our patients are taking their medications. So it's an interesting fact that about 20 to 30% of medications are never filled, and that actually from that non-adherence, actually added an extra zero there, it's 125,000 deaths, minus 10 on there, not 1 million deaths, 125,000 deaths, and it costs about 100 to 289 billion annually. So you can see where adherence has a big impact on our healthcare system. The pharmacists are uniquely positioned because we see the patient's refill histories. We can see if they haven't filled their medication for 30 days or going late on their medications or just not picking it up. So seeing these things, we often will ask patients like what the barriers are, what the problems are with taking medications. and try to identify what we can do to help them out. Some medication adherence tools and strategies we use. Of course, the famous one is pill boxes, which almost every pharmacy has free pill boxes, depending on where they are. But things like dosing spoons, so we don't encourage patients to actually use their home spoons for measuring teaspoons and tablespoons. These are not as accurate, so we will provide those usually. Bubble packing is another thing we can use. Certain pharmacies will actually bubble pack medications for patients, so they can do them all together and just take one pack of medications a day. But again, that depends on the pharmacy. Medication calendars, to show patients when to take medications, also telephone reminders, and newer things coming out like internet and app reminders too. Strategies we use, of course, like education, making sure the patient knows why they're taking their medications or why they need the medications. Trying to support them if they forget their medications, how do we help them remember? We do 90-day supplies so the patients have medications for a longer period of time. Automatic refills, a lot of the chain pharmacies do this automatically to get patients to pick up their medications. A newer thing coming out is refill synchronization. So you have those patients that come to the pharmacy 3 days a week because their medications refill on different days. So insurance companies are looking at refill synchronization as an option so that the patient can just come in one day, get all their medications, and be done. We can also simplify regimens, so going from a once daily or twice daily dose to a once daily dose, or making everything one time a day. We can work on that too. And then looking for alternative treatments that might be more helpful. Question is, what happens to most medications not picked up when ordered? So most pharmacies will go through those medications like a couple times a week. Usually after a week, the pharmacy will put them away. So if they haven't left the pharmacy, we can put them back on the shelf. And what pharmacists will do is they might call the patient and remind them to pick up the medication. Then if we don't see them in a week, we'll put them back on the shelf and keep the prescription on file. So if the patient comes in, they can refill it then. There's not a way for the provider to be notified, unfortunately. Hopefully with the more electronic systems that are communicating and stuff, we might be able to find out. I know at my clinic at Richmond we use MedEnt, and through that system it communicates to a middleman who processes all the electronic prescriptions. And for some insurances, we can actually see if a patient has filled a medication or not just by importing their RX refill history, and we can see what date they filled it, how many they were filled for, what pharmacy they went to, and things like that. So that helps us on our end. But as far as an automatic communication to let a doctor know that something's not being filled, unless it's monitored by the insurance, you might not know. So that's an area we have to work on as pharmacists and providers to increase that communication. But yeah, very good question. So durable medical equipment, this is just equipment that a patient uses to manage a medication or a condition. So probably some of the most famous examples are like monitors are durable medical equipment, like glucose monitors, because we can use them over and over again. And test strips fall in that category too. These are usually available at almost all pharmacies, the diabetes supplies. The rest of them that are listed here, usually specialty pharmacies will carry these, like hospital beds, canes, home infusion pumps. These are usually more independent pharmacies or at least medical supply stores might carry. But these can usually all be billed to Medicare Part B as in boy, which is their patient's medical insurance. And that's who kind of covers it. So that's why only certain pharmacies can cover these, because they have to be certified by Medicare. And some private insurers do pay for these things as well. And again, availability depends on the pharmacy and who they're contracted with. But know that they're available and they're out there, and that pharmacists can help you with those too, depending on who's there. So Medicare Part D navigation, I'm not going to go too into this. I know I'm getting kind of crunched up to Catherine's time, so I don't want to go too far over, and I still have MTM to kind of talk about, and the advanced services. But Medicare Part D, for those of you who don't know, is the prescription drug coverage portion of Medicare, and it was started in 2003, and it provides a prescription drug coverage for any patients who are on Medicare. And coverage is offered through private insurers, and each insurer has their own type of plan with over 40 different plans. being offered here in Vermont alone. So this gets super confusing for older patients because they're on a lot of medications. They have tons of plans out there to choose from. And if you see about the patient costs, there's a lot of things to keep track of. So yes, it covers prescription drugs, but there's also monthly premiums they have to pay, a yearly deductible. They have medication copays still. Plus, they have to worry about a coverage gap where if they spend about $3,000 and they have to pay for whatever is beyond that. So what happens is a patient might start out the year not paying anything for their medication. Then when it comes to July, they've reached this gap, and they end up having to pay for the majority of their medication. So it goes from like a $0 copay to maybe a $200 copay. And that can be surprising for patients on fixed incomes or who didn't realize that was going to happen. And there are also penalties for patients that don't enroll during the open enrollment period either, which this year it's October 15th through December 7th. So there's a lot of moving parts to this. It's not the most easy program to understand. And if you guys have ever worked in Medicare Part D or worked with any of your family members who are trying to pick a plan, it is crazy confusing. The easiest way to do it is going on the Medicare website. And most patients that are the Medicare age don't have computers or are not computer savvy. So this is where pharmacists can kind of help, or interns. It's a great job for pharmacy interns to sit down with a patient and go through these options for Medicare Part D plans to make sure it matches the patient and make sure the costs are what the patient expects. So some of the advanced services, those are the basic ones that we offer as pharmacists. There's been a big push for transitions of care. This occurs when a patient is transferred from either acute care setting to a home setting, or from rehabilitation or long-term care setting to the home setting. So this is anywhere that a patient is physically transferred to a different place. In the hospital, a patient's very well managed. They have tons of medications that are controlling them. But if any of you have been to a hospital and then see the discharge summary that comes in, you see that it's like 15 pages at least with all these medications and all these labs and all this procedure of what's going on at your visit. And it's really hard to find out what medications you should be taking because there have been so many changes. So because of all those changes, there's really high potential for miscommunication and for hospital readmission due to communication breakdown, because patients might not know they need to take their medication after they get out of the hospital, or it's a brand new medication they were taking in the hospital because they weren't taking it physically themselves. They didn't know about it. So Medicare and Medicaid have really made a big push for this. And actually approximately 20% of Medicare patients are rehospitalized within 30 days of discharge. And that's a lot of money that hospitals and we are paying for patients that really don't need to be rehospitalized when all we have to do is make sure they're on the right medications. So because of this, Medicare and Medicaid, as part of the 2013 Affordable Care Act, they added special Medicare reimbursement codes for providers and qualified health providers for patients. And these are actually substantial reimbursement codes if you meet these certain qualifications. So it's for patients who are recently discharged from the hospital. You have to call the patient within 2 days to set up a visit and kind of go over the discharge summary real quick. And they have to be seen within 7 to 14 days after discharge. And what Medicare will look for is they'll look for that initial phone contact and that 14-day follow-up to allow you to bill for these extra codes. And like I said, these are actually on the magnitude of like $100 if you do these. So it's pretty good reimbursement because they really do prevent a lot of rehospitalizations. Especially when you're thinking about some of the more complex issues like pneumonia and heart failure and diabetes. So what you do in a TOC visit, or what pharmacists can do, or anybody can do if you're qualified. So we collect and review all the discharge information from the patient. So we get the discharge summary from the patient's hospital, and we go through it with the patient. We give education to the patient about their medical condition and their medications. We also determine what their need is for follow-up and make sure they're actually plugged in for that follow-up. Because often patients will go back to their specialist in a month or so after being discharged, but really it's the family medicine or the primary care doctors that kind of handle them in that interim period. And then also, like I said before, we coordinate for referrals and make sure follow-up with the providers as needed and get extra services if they need them. So we really kind of tuck them in, make sure they're okay, make sure they know what their medications are for. And that's why it's so important to have this contact within 2 days, and then the 7-day follow-up is that you really need to catch those patients early on after discharge when they're in their critical stage to make sure that things are okay. Health screenings, these are becoming a little more prevalent. You've probably seen blood pressure screenings at pharmacies, but because pharmacists are trained as healthcare promoters, we can offer a variety of screening services to patients, and there's more and more coming out every year. So some common examples are like blood pressure screenings, tobacco cessation, diabetes and heartburn, osteoporosis, and high cholesterol, the more common ones. And we can actually do some lab testing with some of these, which is what I talk about in the next slide here. So there are CLIA waived point-of-care testing devices out there. And what this basically means is a CLIA waived point-of-care testing device just means that you don't have to be a specialized laboratory to do the test. They're waived because they're guaranteed to be accurate. Pretty much anybody can do them, and they're going to be accurate if you follow the right instructions, is what the CLIA waive means. So they are diagnostic tests, and they're performed outside the laboratory. So we can do everything depending on the pharmacy. Again, we can do cholesterol screenings. We can actually do Hep C, HIV, and influenza screenings, Group A strep, and of course A1Cs and INRs, depending on what the pharmacist is comfortable with doing. And actually some local pharmacies, I know Rite Aid is piloting it here in Burlington, are implementing screening and treatment protocols for influenza and strep. So if a patient tests positive for influenza, they actually have a standing order where the pharmacist can give the patient a Tamiflu prescription. Or if they have strep, they can actually give them an antibiotic to treat the strep. What is a Cholestech machine considered? It is CLIA waived, and Cholestech would be like the cholesterol machine, and I'm pretty more sure most Cholestechs are CLIA waived. So if you're interested in having that maybe in your practice site, might be something to look into. I know the Cholestech can do more, depending on the brand you have, can do more than just cholesterol. I think it can do A1C and stuff too. But for some of these other devices, I know there's one device that can do the Hep C, HIV, influenza, and strep, and I think it's the one that Rite Aid has, what they're doing the pilot program with. Do these tests have to be ordered, or can a patient just come in and ask for screening? Yep, the patient just comes in and they can be asked to have a screening done. So there's no special order. The patient will have to pay for the screening, the cost of the screening possibly. Sometimes insurances might pick it up, but patients more often pay cash for them. How does the pharmacist screen for osteoporosis? Good question. There's actually these, I wish I could show you, I don't show you a picture on it. There's actually a device where the patient can put their foot in this bath of water, and it's an ultrasound machine that actually looks at their heel and the density of their heel to kind of predict what the density of their bones are. Now they can't diagnose using the heel screening, but they can screen patients. So if they identify patients with a low bone mass, they recommend that they go to their doctor to get a full-on bone density screening. So it's more of a screening tool as opposed to a diagnosis. So what kind of waiver do they sign? So the CLIA waive is something that the point-of-care testing comes with. It's been CLIA waived. As far as the patients and what they sign, they probably have to sign like an agreement to let the pharmacist test them to make sure that everything's copacetic there. As far as protecting the provider, because it's patient initiated and it's run by the pharmacist, there is no liability for the doctor. In fact, when we talk about more advanced pharmacy services and what a pharmacist can do, the liability of the provider ends where the scope of the pharmacist's practice begins. So for these more advanced things like these screening tools or screening tests, if something happens at the pharmacist's point of care, it is the pharmacist's liability, not the doctor's liability. So that's kind of the protection of the provider. How do you handle positive Hep C and HIV results? That's a great question. Often to do these tests, you have to be trained on how to do them, and part of that training includes counseling on how to tell a patient they are positive for Hep C and HIV. I don't know of any pharmacists, and I know Rite Aid is not doing the Hep C and HIV screenings right now. I don't know what their propensity is to start doing those, but those are kind of sensitive screening tests that even me as a pharmacist, I'd want to be a little more trained on how to break that news to a patient and then what to do next for resources. We'd probably handle them just like any other positive screen, is letting patients know education about the disease state, definitely referral to where they need to go next for a double check and treatment, and really getting them plugged into the health care that they need. But really right now, influenza and strep are the most common, but there are pharmacies out there doing Hep C and HIV screenings. So, great questions. All right, so disease state management. This is where I was kind of talking about the expanded scope of pharmacy, and this might come more into play in that asking about providers and where people stand on things. So the great thing about Vermont is that we have an awesome collaborative practice law on the books where pharmacists can work with providers to provide care for patients. So under a collaborative practice agreement with a provider, a pharmacist can actually manage specific disease states. So we can order labs, we can actually initiate or discontinue medications, adjust medications, and refer to other healthcare professionals as needed if necessary. So really the flow is like the patient's diagnosed by their provider with a condition like diabetes or hypertension, and then they're referred to a pharmacist for management. So again, pharmacists don't diagnose. We just screen or recommend things to patients, but we can manage the chronic disease states. And it depends on, what the pharmacist is comfortable in doing, what their setup is for their practice, and things like that. So this is kind of the VA model. This is how things work in the VA setting is, doctors don't manage cholesterol or diabetes or anticoagulation in the VA setting. They actually have special pharmacy clinics that are set up for those special disease states that are managed. So the question is the same-day referral with pharmacist? Sometimes it is if the pharmacist is there. I know for me at my clinic where I get pulled into rooms, the doctor will come ask me and I'll go see the patient with them. But sometimes when I'm not there, they'll actually schedule a separate visit to follow up with me to talk about that disease state. So where it gets a little hairy is in the billing process, because you can't bill for a patient twice in one day at the same practice setting. This is getting a little more advanced, but I usually don't bill if I'm seeing the provider with the patient with the provider, but if the patient's coming in separately, I do bill a little bit. Yeah, it just depends on what the pharmacist setup is. They might have to wait a week or so to go see the pharmacist. But that gives us time to actually spend more time with the patient and give them more education and stuff like that too. But usually there's the chronic disease states that we do kind of manage, the common ones we do, and this isn't the all-inclusive list, but I do a lot of diabetes in my own clinic, hypertension, of course cholesterol too. Anticoagulation is a big area for pharmacists too, because of the warfarin and everything, common frequent monitoring and stuff. It kind of takes away that burden from the providers and kind of shifts it to the pharmacist, where the provider can actually end up seeing more complex or acute patients, and they actually get more patients in throughout. Mental health diseases, yes, there are actually pharmacists. And it's actually a specialty of pharmacy of psych practitioners that are out there. In fact, we have one here at the school, Clayton English, who is a pharmacotherapy specialist in psych medications, and he works in the inpatient setting at UVM Medical Center, working with the doctors there. But I have a colleague that used to work down in Albany at the VA Medical Center, and she was a psych pharmacist, and she actually saw patients with depression and anxiety and managed their medications, counseled them, so she had that specialty training too. So, with Vermont and its big need for mental health specialists, that could be another area for pharmacists, but it's going to require some extra special training for pharmacists too. I know I wouldn't be comfortable totally with just doing any kind of mental health, but I do deal with depression and some anxiety and some bipolar at my practice site for some minor management, but it's going to depend on the patient. But that's definitely an option for pharmacists as well. So again, this can be conducted either at the provider's office or at the pharmacy, depending. And the location really dictates the type of reimbursement. So if you're doing this at the pharmacy, because pharmacists aren't recognized as healthcare providers under the rules of CMS, then they can't bill like other doctors, but we can do MTM services and bill that way. But look, I'm almost out of time, so give me 5 minutes and I'll wrap up with this. So disease state management, again, we have open collaborative practice agreement in Vermont. We can do a lot of things. It must be renewed yearly. It's kind of an agreement with the pharmacist of what they can manage as a pharmacist. So if I have diabetes, what can I prescribe? What can I change? What can I do? Some are more open, some are very, very specific, and it's up to the pharmacist and the doctor themselves. If the diagnosis is made by a provider and then referred pharmacist, who is liable if the patient does not show up for RX appointment? So that's a good question. Usually it depends on the pharmacist, or it depends on the setup. For me, I call the patient and see what's going on, see if I can reschedule them, see if they're still interested in seeing me. But then I let the doctor know that, hey, the patient didn't show up. What do you want to do? Do you want to schedule them to come back and see you? Once the doctor makes the referral, it's back on the pharmacist to kind of follow up with that patient. So that's at least my practice. Until I hand that patient over to the doctor and have that warm handoff, they're my responsibility. So again, it depends on the setup for the patients. And MTM, sorry I didn't get enough time to go through this, but just a summary of what MTM is. It's different from dispensing. It's actually a comprehensive assessment of a patient's medication. So it's kind of like what I was saying with the disease state management, where the pharmacist can work with the patient and make changes. For MTM, this is more of what you're going to see in the community pharmacist setting, where a patient scheduled a visit to see a pharmacist to go through all the patient's medications, to see if there's any problems, if there's any extra information they need, and ask you to make recommendations directly to their providers to make those changes. Now, and these are the components of MTM, so collecting the information, assessing medication therapies, developing a list of medication problems, and then creating a plan to resolve them. That plan for resolution can either be a communication with a doctor or a change in what a patient's doing already. Depending, I'm going to skip through the components again. You guys can read through these, and feel free to email me with any questions. But just for the follow-up for what happens, I'm trying to get through where, there we go. So the big difference with MTM versus regular dispensing is just that the patient comes in for an actual sit-down visit with the pharmacist. We review all their medications, and usually because it's in the community pharmacy setting, we have to ask the doctor if there can be any changes done. We can't make direct changes unless there's a collaborative practice agreement in effect. But usually what we'll do is we'll fax over our notes to the doctor and make those suggestions. We'll also go through and tell the patient what we recommend would be changed too. Anyway, MTM is probably the most common thing you're going to see out there is advanced pharmacy practice in the community setting. But just be aware of it. It's more comprehensive for patients. So anyway, sorry, Catherine, I didn't mean to overspeak for your presentation, but any more questions before I shut up? All right. Well, I'll still be here, so if there's questions at the end, feel free to ask. So I will turn it over to Catherine now.
Okay. Well, thank you, Michael. That was an awesome presentation that you made, and I think that you pretty much covered everything that we do and can do. I'm just going to quickly go over some immunizations and what would be important in dealing with people in the agricultural setting. So the main reason we really want to make sure that these people are able to get immunizations are because of the diseases, and that kind of will go back to what we spoke about last week with the zoonotic diseases, that there was a few diseases that would be a really good thing to get immunized against. You have the potential for environmental exposure to tetanus, and also if you do have any of the migrant workers that work on the farms, quite often they don't have the same immunizations that that we do here in America. So there's also the potential to get things you normally wouldn't run into. this is just some facts on how much dollars the flu vaccine or the pneumonia vaccine will save people. And the other thing I just wanted to touch on is why we're so accessible. As Michael had said, the patients see us more often. It's easy to come to a pharmacy. Hours are better, and we can always do the immunizations right there, especially if we have a patient that comes in and said, hey, I stepped on a nail, or I got a wound. How long has it been since you had your tetanus shot? We can do that right there. Save us from saying, well, you need to go to the doctor, because they aren't going to have time to do that. The other point I wanted to make quickly was that in Vermont, the patient has to be 18 years old or over. And also the most common vaccinations that we do see in the retail pharmacy would be the flu vaccine, the shingles, pneumonia, and the tetanus, or the tetanus, diphtheria, and pertussis. Recommendations for the tetanus is one of the Tdap doses, and then a follow-up with a tetanus every 10 years, flu vaccine yearly. Shingles at this point is 1 dose after the age of 60. The pneumonia conjugate is a one-time dose, and then the pneumonia polysaccharide is either 1 or 2 doses depending on the age that the patient is first given. That was in one of the handouts that you guys had for required readings. I do have a question about, do insurance cover vaccines at a pharmacy most of the time? The answer to that is yes. Quite often we give the pneumonia shot. If the patient has Medicare Part B, it's totally covered. Flu shot, if they have Part B, it's totally covered. If they have private insurance, quite often with the flu vaccine, it's a 0 copay. And the tetanus vaccine, if it's not covered, the Tdap and the tetanus would run about $40 for the shot. And mine was a lot quicker than Michael's, because he spoke about quite a bit of information that pertained to the pharmacy, and I just wanted to touch base with you guys with the immunization. So any other questions that anyone would have? Okay, I've got a question asking whether we need an MD order for immunizations. In Vermont, we have the ability to do a collaborative agreement with a physician, and with that we would make a contract with the physician over certain immunizations that the pharmacist can give if it's appropriate, such as the flu, the Zostavax, the pneumonia vaccine, and the shingles vaccine. I also have another question. Do you see the use of pharmacy for migrants? That certainly is something that they can have done at the pharmacy, especially if they don't have a regular doctor. I know in our areas quite often they will go to the open door clinic, but the pharmacies are being open on the weekends, and they're able to come in and get a shot for the flu. Let's see. Okay. Next question, farmers don't want to see a physician. Do you have an easier time talking to you thereby avoiding the physician? We do get that with farmers and pretty much any other people. They'll come in and they'll ask us our opinion. We will make our professional judgment as to whether we feel that it needs to go to a physician or if it's something that can be taken care of with over-the-counter medications. And then I have another question. We do have a process for notifying the provider. We do fax a copy to the provider that we have given the shot, to the whichever provider they normally see, so they do. I'm not sure if the open door clinic charges for the vaccines. And I'm a little confused, Corey, the question about are we obligated to provide screening tools, follow-up, and as far as, can you give me a little more detail what you're looking for?
Hey, Catherine. It looks like Corey's saying that may have been something related to Mike's presentation there. So, Mike, if you also want to jump in, please go ahead.
Oh, sure. I just wasn't sure if that was directed to me. Okay. So as far as the screening tools and follow-up goes, if a pharmacist for the follow-up, if the pharmacist is managing that patient's disease state, then yes, they need to provide follow-up and all that kind of stuff. As far as screening tools go, if the pharmacist is like in a clinic or a community for the clinical setting where we're doing like a wellness visit with a patient, then we might do screening tools. If it's for a specific disease state, if there's a screening tool available for that disease state, we might use it. But we definitely use those screening tools sometimes if we were going to do like heartburn screenings or whatever in a community pharmacy setting. So we're not necessarily obligated, but we're definitely encouraged to, just like any other healthcare provider, to do it. And follow-up is always something we encourage, even with my students here. Like, that's one of the things I harp on them the most, is making sure they tell the patients when they need to follow up the next time with somebody and not just leave them hanging, even for an over-the-counter medication issue, because you never know when a patient might treat their chronic migraines for 3 or 4 years just with over-the-counter therapy and they need extra help. So got a last question up here. So just kind of like brainstorming like where you can see using pharmacists in your patient care team, especially in the rural setting. So hopefully we gave you some ideas of where you can utilize your pharmacist or lean on your pharmacist a little bit more, or at least call your pharmacist and get to know who they are.
Hello, this is Jean. I want to remind all of you training participants that it's very important for you to take the quiz that will be available on the course website. And you need to actually take the quiz to get credit for this webinar. I thank our 2 presenters very much. And unless there are questions that people have yet to ask, I see we have one.
Yeah, it looks like we have a couple there, Jean. There's one from Alison, Catherine, or Mike, if you're able to answer. Is there any connection with local pharmacy and open door clinics?
We do at our pharmacy. We have a connection with the open door clinic. If a patient does not have insurance, we have a prorated pricing schedule for them so that we give them the best possible price that we can. And at that point, we also would make sure that if there was a generic or something equivalent that would be less expensive that they could afford, that we would give that option.
And then, Catherine, I don't know if you could answer this one too. There was the last one from Katina about, do you think the farmers without PCPs are less immunized?
I would say yes. I'm thinking that they probably are, because a lot of the people that come to us they come from the doctor's office, where the doctor has suggested that they get the particular vaccines. And unless we do have them come in for regular refills, we may not catch it. Yeah. That they need a shot.
I actually got done teaching the immunizations class to the students this past Saturday, and one of the slides in there was saying that even that doctors are still one of the most common sources of referral for an immunization, even with pharmacists now giving it to them. So, yeah, I think it totally supports Catherine's observation that patients with PCPs are more likely to get immunizations in general, because somebody's there to kind of nag in a way to get immunizations for somebody.
Okay, great. It looks like we have 5 minutes left, so if anybody has any last-minute questions, please go ahead and enter them in the chat box. I'm not sure whether any were missed from the section that Mike had to skip through quickly, so if there were any that need to be covered that were missed from back there, then please give us a heads up so we can go ahead and get those answered now too. I see a couple of people typing there, so. Okay, there's a question from Patty here. Mike or Catherine, I'm not sure which of you wants to go ahead and address that one.
Oh, yeah, definitely we would advise a wound evaluation at that point, Patty.
Okay, well, I'm going to go ahead and stop the recording. Mike and Catherine and Jean will be around for a couple more minutes, so we'll keep an eye out for any other incoming questions. But other than that, I'll go ahead and end the recording here.
Thanks, Lucy.